To the cloud. And then we get started in 1 second. I'm going to see if I can go through this. Hold on. And I'm going to, so what I'm going to do then is just kind of make sure we start at like the second part right here. And in class, we started talking about just Boyle's law of ventilation, right? And that has to do with how pressure and volume are related to each other. And this is how ventilation is the movement of air into and out of the lungs. Respiration is the actual movement of oxygen and carbon dioxide in the lungs, right? Oxygen has to go into our red blood cells. Carbon dioxide has to go in reverse from our red blood cells and our bloodstream, right? It's got to go into our lung matter so then we can exhale it. You know, it's a little bit harder to kind of discuss when it's just a voiceover because I can't really draw anything, but keep in mind that there's an inverse relationship between the two. I want you guys, when you're doing this and when you're watching the videos, the easiest way to understand how this law works is to take a deep breath. If you take the deepest breath possible, what happens is that your chest increases in volume. As your chest increases in volume, your rib cage increases in volume as well, which causes the lining of the ribs, called the parietal pleura, to also increase in volume. As all that increases in volume, the parietal pleura is going to pull the visceral pleura open. The visceral pleura is kind of a connective tissue that's found on the lung matter itself. And when it gets pulled open, it's going to pull all the alveolar cells open as well. So you have this kind of suctioning effect, all because your chest is moving outwards. As your thorax moves out, your rib cage moves out, your pleura moves outwards, which pulls the lung matter out as well. As all of that moves out, you have increased volume. And you have increased volume, the pressure always drops inside of it. So in our lung, as the volume increases, the pressure drops. Now there's more pressure in our environment because we really can't change the pressure environment, right? It's going to be what it is. So that's going to stay constant unless we move around and go to a different environment, like we fly to Denver. Now we're in a different environment. We're a little bit higher above sea level. So we're going to have a change in air pressure. But if we're here in Milwaukee, no matter how far we drive in Milwaukee, we go to Chicago, we're still at the same sea level. So we're going to have the same pressure. In order to move air into our lungs, what we need to do is somehow create negative pressure in our lungs because whatever is in our environment is going to stay constant. So you increase volume, increases the amount of space we have in our thorax, which increases the lung size, which increases the volume, which decreases the pressure, which allows you now to have negative pressure in the lung. That negative pressure allows air to go from the environment where it's unchanged, it's normal, sea level. Now there's less pressure in our lungs. Now there's negative pressure. Air is going to go from high to low. It's going to go into our lungs. That increase in volume is almost always going to be directed by the diaphragm. Now, other muscles can help in that other muscles can kind of make the lungs larger, or it can shrink the lung matter and the chest size and increase the pressure in the abdomen even, so then you can exhale faster, right? So we have other ways, accessory ways to increase or decrease respiration, but none of this works without the diaphragm. The diaphragm is required. Without the diaphragm, nothing else works. So you take a look at these pressure changes, we don't need huge pressure changes, right? What we're going to see is that here, at rest, the pressure in the environment, we say it's zero. The pressure in the alveoli of the lung is zero. So we have equal pressure, in other words. When the thorax expands, the pressure environment unchanged, still at 0. But with increasing thoracic expansion due to the diaphragm, take a look at the pressure now. It's at -1. That's on the inside. That's all we need. That's all we need. Just a slight decrease in pressure that allows air to move from high pressure now in the environment to lower pressure in the lungs. Eventually, that lung pressure stabilizes, and then we exhale out, creating negative pressure right here, a positive pressure. Now, what happens with this positive pressure to exhale is due to the thorax recoiling, the lungs recoiling. I give the example in class about what happens if you blow up a balloon and you're holding the actual opening, that nozzle of the balloon. What happens if you let go? If you let go all of a sudden, the recoil will cause that air to move out suddenly. That's what's going to happen in our alveoli in the lungs. The recoil allows you to go from -1 to +1. +1 allows you now to have greater pressure in the lung matter, alveolar pressure here. Now we have greater pressure in the alveoli than in the air. It allows you to move that air outwards, right? Now, this is all due to the diaphragm. If we want to take deeper breaths because we're exercising, and this is what makes the first couple minutes of doing cardio so hard, is because we're going from a resting respiratory rate of 8 to 10. Now we're going to increase it to almost 30. So almost a 300% increase in respiratory rate. You add it with it, we are also going to add, right, deeper breaths too. Not just more breaths, but deeper breaths. So it's going to create some kind of, it's a struggle to get all that air in. And what happens is when we exercise, your diaphragm contracts even more than normal. Your accessory muscles, like your intercostals, like your pectoralis minor, like your scalenes, start to activate as well, all to get increased amount of negative pressure so then we can bring more airflow. And even better yet, because that's not a struggle enough, what you're going to do is need to exhale faster. So if you exhale faster, you can take your next breath faster. So what happens? Well, after you take your breath and it have to activate all those accessory muscles to take the deep breath, you need to now take a faster exhalation. And how do we do this? We activate your abdominal muscles. That's why you see people sometimes when they're tired and playing a sport, sometimes they do what's called, right, a tripod position, where they put their hands on their knees, trying to catch their breath. In a tripod position, what you're doing, tripoding, is decreasing the thoracic size suddenly. And then the abdomen starts to contract and it forces the diaphragm up fast. So then you can exhale faster, right? Now, why is it so important to exhale faster? Because during normal quiet respiration, 2/3 of the time required for respirating or for ventilating here, right? 2/3 of the time required for breathing. 2/3 of the time is for expiration. Only 1/3 is inspiration. So if we decrease the time required for expiration, we can take our next breath faster. More breaths, more oxygen in, more carbon dioxide out. So this is the reason why it feels so comfortable when we are doing, exercise, when we're playing basketball, when we're playing football. It feels so much better to tripod when we're trying to catch our breath. It allows us to exhale faster, so then we can inhale faster. Either ways, we're trying to get as much carbon dioxide out by exhaling faster, and by inhaling and taking our next breath quicker, we're able to bring new oxygen in. That's why we do have that kind of, predilection of doing that tripoding. Now, we talked about this a little bit more, so I'm not going to go over it again. Important thing to know about measurement of lung functions. Residual volume is important, is highlighted. And in class, the residual volume is this area right down here in the blue, all right? Residual volume of 1,200. What does this mean? This is the one lung measurement, no matter how good our ability to measure airflow in your mouth and in your lungs, we cannot measure our residual volume. Residual volume is the amount of air that's in our alveolar cells, so trapped in the lung matter, even after we've taken the deepest breath and exhale as far and as fast as we can, right? So you have exhaled as hard as you can. You've stood up and then you bent over and blow out into a machine. At that point, we have what's called the maximum expiration, right? Even after that, there's still almost 1.5 liter left of residual volume. This residual volume is important because it has very similar concepts to what happens with a very small balloon. When we have a very small balloon, we stretch it a little bit. We know it's going to be hard to get air in, so we stretch it to decrease the surface tension. The first couple breaths we put into a balloon, it's impossible, right? You're taking the breaths, you're sucking in, and then you're blowing out as hard as you can, and the balloon expands like not even a millimeter. And then your kids want to help, so you know your kids aren't going to be able to do it if you can. So what you do is you get a couple breaths in, and then you give it to them, so then they can finish it off. Why does that work? Simple. After we put in a couple breaths in, you stretch out the latex enough that the surface tension on the latex is substantially decreased. After that point of maybe 2 or 3 breaths into the balloon, you've decreased the surface tension so much that it's incredibly easy to add extra air into the balloon and fill it up completely. That's when you give it to your son or daughter, so then they feel like they're helping. Now, that's the same concept, right? The thing is, it's always hardest to blow in a balloon when the balloon is collapsed, when you have to start at a point zero where there's no air in it. That's the same thing that we're going to see in our lungs. The lungs are made out of these tiny balloons, these alveolar cells made out of type 1 pneumocytes. These alveolar cells have surface tension, just like a balloon. Now, unlike a balloon, we can't stretch it, but we have surfactant to decrease the surface tension. We have other stuff to decrease the surface tension. One of the main ways that we prevent a collapse of the alveoli is to keep air in it at all times. It would be like what happens with our latex balloon if there's always a little bit of air in it. So when you let go of the balloon, there's always air stuck in it. Well, next time you try to blow it up, there's always air in it, right? So you don't have to go from a position where there's no air and everything's collapsed and you have to struggle to put the first 2 breaths in. Well, if you have a balloon that's already partially inflated, it's very easy to add the extra air and to fill it up. That's exactly what happens with our residual volume. That is the extra air we keep in the lungs at all times. It prevents the alveoli from collapsing. So when you exhale, there's always that air in there. That air in there is not measurable, but we know it's in there. So when you take your next breath, there's always already air in these small alveolar cells. So then you're not breathing and you're not trying to bring air into a collapsed alveoli. If you were, you'd never be able to breathe normally. So what we do have instead is that when you exhale, there's always a little bit of trapped air that stays in the alveoli. When you take your next breath, there's air. So you don't have to go from a position where the actual alveolar cells are collapsed. It's partially inflated already, and now you're just topping it off. That's what makes the residual volume so important. Now, everybody's residual volume should be very similar because the residual volume is very similar to our dead space. There's anatomic and physiologic dead space. Dead space is important because this is the area of your lung matter where there's no gas exchange. So this is like the piping, and that's it, right? The actual lung matter itself is going to have 2 zones. There's the respiratory zones, where you're going to have alveolar cells, where you're going to have gas exchange occur. That's the alveoli cells, that's the terminal, the respiratory bronchial region, and that's about it. The rest of the respiration respiratory system, including the nose, the nasal, oral, laryngopharynx, the trachea, the primary, secondary, tertiary bronchi, all right, the bronchioles, except for the respiratory bronchioles. All those other regions are all dead space. And everybody's dead space is dependent on height and weight. So it's all based on height and weight. So people that are taller always have greater lung capacities because they have more room in the chest. People like me who are really short, yeah, there's a limit. I'm not running no marathons, right? And so, I'm very good at very short sprints and very short, powerful movements. But anything that requires more than, I don't know, a couple miles of jogging, it's not happening, right? Lung capacity is very different in people who are taller versus people who are shorter. Now, physiological dead space is a combination of your anatomic dead space plus any kind of diseases that person might have. Smoking, asthma, chronic bronchitis, these are all can cause changes in your physiological dead space. So if you have somebody that's 5'10", 130 pounds, and you compare him with somebody that's 5'10" and 130, they should have very similar anatomic dead space. But if one is a smoker and they have emphysema, while the other one is, a health nut, well, the smoker is going to have more physiological dead space. Gas exchange, and really, when we're talking about Dalton's law, I would have you go back to my other videos because it's hard to describe this without writing down the numbers. But Dalton's and Henry's law is what allows us to have the ability to go past 100% oxygen saturation. It allows us, under great enough oxygen, we can give people 100% and then greater oxygenation because we can push oxygen as a gas into the plasma. Now, Henry's, what we're going to see is when we're breathing with Dalton's law right here, right? And I'll try to explain it a little bit. If you don't understand, then just please go watch the videos, the other videos I have where I'm kind of at the board. Now, with Dalton's law, it's just telling us, and you will need to know what these laws are, just kind of generally. I'm not going to ask you to do any numbers like this. I'm using these numbers to just reinforce what I'm saying here, right? So in our environment, we know that 79% of our air is nitrogen. 79% is 0.79. Now, we also know that when we add all the gases together, it exerts a force on us equal to 1 atmosphere. 1 atmosphere is 760 millimeters of mercury. When we're looking at that, how do we determine how much oxygen do we have? That's important, right? Nitrogen is important, but indirectly. Oxygen is a lot more important for us because that's what we need to make ATP. So how do we determine the concentration of a gas? Well, unlike something like sodium chloride, where we can see it, we can see the crystals, right? By doing that, we can, use moles as a concentration. Gases are unseen. Gases have no smell. So all natural gases have no smell. Nitrogen, oxygen, carbon dioxide, it has no smell and you can't see it. So how do we know how much of the gas we have? We know based on the amount of pressure it exerts. So when we are at sea level, all the gases we have exerts a pressure of 760 millimeters of mercury, which is 1 atmosphere, we call it. Now, how much of that 1 atmosphere is due to nitrogen? About 600 millimeters. So a lot of it, right? Almost 80% of it is due to nitrogen, in other words. So when you're breathing in a lot of the air we have, you're breathing in 4 times more nitrogen than you're breathing in oxygen. How much oxygen do we have? About 150 millimeters of mercury, 20% of the available gases. Now, that at rest, it's good, right? 152 milliliters. If you are, let's say, if you're in good shape, you don't have any diseases, that's enough for us to survive, to have 99% saturation. But there are people where that 150 millimeters of mercury is not enough concentration of oxygen. Let's say you have COVID and you need more oxygen. Room air is not enough. You're not going to have enough oxygen available to you at 150. Remember, that's a concentration of that gas, right? So what do? We give people 100% oxygen. At 100% oxygen, that means at 1 atmosphere, that means that 760 milliliters of air, all of it is going to be oxygen. So before 600 millimeters of the air is nitrogen, now 760, all of it is going to be nitrogen. Going to be oxygen. So you've increased how much available oxygen you gave somebody by giving them 100% oxygen at 1 atmosphere. You increase it from 150 to 760. That's a 400% increase in oxygen. That's a lot, right? But we don't normally give somebody oxygen through their nose, right, through a mask at just 1 atmosphere. We give it maybe 1 or 2 atmospheres so we can shove that oxygen into their lungs, make it easier for them to breathe because there's so much positive pressure. Well, can you imagine? And the very bottom part right here, right? When we give somebody 100% oxygen at 3 atmospheres, that means all of that gas we're giving them is oxygen, 100% of it. So that's 760 millimeters of mercury of oxygen. That's already 400% the normal. And now we're increasing it to 3 atmospheres. So we're multiplying that 760 times 3. What we have then done is increase the available oxygen for that person to breathe from 150 normally through the environment to now almost 2,300. That's a huge increase, almost 1,000% increase in how much oxygen the person can use, that a person can bring into the lungs, right? Because of that, we can push that oxygen into a gas, right? That gas into, that oxygen gas can be pushed into the liquid of the plasma. Now, people always have a hard time kind of wondering, what do I mean by pushing this gas into a liquid like plasma? We see it all the time. We've seen carbonated beverages before, our sodas. Our sodas are going to have carbon dioxide into that liquid. When your soda goes flat, the carbon dioxide gets released, right? As it gets released, it goes flat. It's just like any beverage, it's like water, right? Well, carbonation is putting carbon dioxide gas and pushing it into that liquid. The thing with carbon dioxide is because of Henry's law right here, Henry's law tells us that some of these gases have an easier time to be pushed into a liquid or solution. We call that solubility. So when we discuss carbon dioxide, we say that carbon dioxide has a higher solubility coefficient, meaning that at any amount of carbon dioxide, at any concentration, at any pressure of carbon dioxide, that carbon dioxide is more likely to go into a solution because it's got this higher coefficient, this higher likelihood of wanting to go in. Now, each gas has a different coefficient, right? Different likelihood of going into solution. Carbon dioxide is really high. That's why we use carbon dioxide to carbonate the beverage. Now, we can push oxygen into the liquid, but nobody's ever heard of an oxygenated beverage. The reason why is you need so much oxygen. Oxygen has a very low coefficient, very low. And in order to push oxygen as a gas into any liquid, you need such high pressures of oxygen that it can be explosive, right? And getting that much oxygen to push just into a fluid will also make your price of your soda incredibly expensive, hundreds of dollars, because of how dangerous it is and how expensive it would be to get oxygen, that much oxygen, just to oxygenate a solution, right? So just keep that in mind, that there are reasons why we don't oxygenate our sodas or beverages, but we do carbonate. Now, when we do have so much oxygen we're giving you, Let's say I put you into a hyperbaric oxygen chamber. At a hyperbaric oxygen chamber, I can increase the pressure from 1 atmosphere to 7 to 8 atmospheres. At that high, right, 8 atmospheres of pressure, that means that you're multiplying 8 times 760, right? So we're talking about almost 6,000 millimeters of mercury of pressure. And again, oxygen is very explosive. So if any spark occurs at that high oxygen content, everything blows up. Everything catches on fire. But so we only do this in a hyperbaric oxygen chamber where we can limit the possibility of that, right? And very few places have hyperbaric oxygen chambers because of it. Now, why would we want to give somebody so much oxygen? Because of carbon monoxide poisoning. Carbon monoxide binds to red blood cells at a much higher affinity. And if we don't use a hyperbaric oxygen chamber, we can't push out the carbon dioxide and put oxygen in. Right, so that's how we kind of go into it. We talked about shunted blood as well in our class before. Now, keep this in mind with shunted blood, it allows us to survive conditions like a pneumothorax, a collapsed lung. A pneumothorax, a hemothorax is a collapsed lung. And let me just explain that for a collapsed lung to occur, all we need is a little disruption between the parietal and the visceral pleura. So the parietal pleura seals the inside of our rib cage. As it seals it, it forces us to have a vacuum in our thoracic cavity. So when the rib cage moves, when we inhale, there's a vacuum inside the thoracic cavity. That vacuum causes the lungs inside of it to expand. Now, what would happen if there's no more vacuum? Well, usually that can happen through a car accident, some kind of trauma. Trauma causes a rib to break and punctures that parietal pleura. Puncturing that parietal pleura means just air going inside into the abdominal, to the thoracic cavity. Now you have air found between the parietal and the visceral pleura. That air, just air from the environment, right? Now that acts as a barrier. It prevents the parietal pleura from pulling on the visceral pleura, right? It blocks the reaction between those two. Your ribs and your chest will actually work harder to expand. But because you no longer have a vacuum there, you can't pull the lungs open. And now you have a collapsed lung. The lungs then retract. Now, this shunting of blood is important because, number one, it allows us to move blood to areas that are better oxygenated. And it allows us to redirect blood from areas that are poorly oxygenated or ventilated. All right? So the area that has a collapse, let's say your right superior lobe of your lung is collapsed. As it collapses, what's going to happen is the blood vessels there is going to vasoconstrict. It's weird, but we're going to kind of mention this right now. But when and I want you to write this out sometime. Write down what happens in the lungs when there's a lack of oxygen and what happens in the systemic circulation, right? There's always that difference between the two. What happens in the lungs is different than what happens everywhere else. So in the lungs, a lack of oxygen means you're not bringing in oxygen. That's a bad sign. So low PO2 in the lungs is a low oxygen pressure. That happens because you have a collapsed lung. What happens? Well, no air movement. If there's no air there, why would we want to bring blood there? You're just going to pick up carbon dioxide. So we're going to vasoconstrict the blood vessel. The vasoconstriction occurs due to that low PO2 in that area. What happens then? The area that has high PO2, the other lung, the whole left lung's not affected. Remember, right superior lobe, right? So the left lung isn't affected, is well ventilated. The right middle and inferior lobe isn't affected, is well ventilated. So those blood vessels there dilate. High PO2 in the lungs causes vasodilation. When it does come, it allows us to, right? When it does come, right, it allows us then to kind of move around, move that blood to that area that has better ventilation. Perfect. Perfect, perfect, perfect. We bring blood to the area with a lot of oxygen. Then we remove blood from the area that doesn't. Now, in systemic circulation is different. So what I want you to do is write lung or pulmonary and then systemic, right? So I have a category here, systemic and versus lung, pulmonary. And then on each side, write high PO2, low PO2, and be able to understand what happens under both conditions because it's different. In the lungs, when there's low PO2, it's a sign of a bad condition. You vasoconstrict, so then you can redirect blood to the other areas where there's better ventilation. The opposite's true in systemic circulation. In systemic circulation, what happens? Areas with low PO2, low oxygen, means that they're more active. Our body needs oxygen and glucose to produce ATP. So if I'm working out and I'm jogging, I need a lot of blood flow to my legs. All right. You need to contract the muscles, which requires a lot of ATP. Where do we get ATP from? We get it from the bloodstream. We get it from oxygen and glucose. So if you have a very active tissue that needs a lot of ATP, you're going to be using up a lot of oxygen. You're going to be using up a lot of glucose. So those areas are going to have very low amounts of oxygen. Makes sense, right? That low oxygen in that area is a sign of activity. So the more active the tissue, the more blood we want to bring in. Again, it's 100%, it's like 180 degree difference here between the lungs. In the lungs, low PO2, vasoconstriction. Redirect blood flow to other areas that's well ventilated. In systemic circulation, low PO2 is a sign of activity. We want to bring more blood there. As we bring more blood to that area, we vasodilate that area, allowing us to bring fresh blood in with fresh oxygen and fresh glucose. So then that muscle can continue to work. Now, what happens when there's low O2? If there's low oxygen, then what we're going to see, low oxygen in systemic circulation means it's not active. Because it's not active, why bring blood to that area that's not quite as active? So we vasoconstrict those areas slightly. So we can redirect blood flow and target it to the most active tissues. Now, where's the most active tissue? When you're exercising, skeletal muscles, heart. When you're not exercising and you're just resting, that's parasympathetic, right? So GI tract, kidneys, internal organs at that point. You're going to redirect blood flow there. So there's always this yin and yang, push and pull between sympathetic and parasympathetic. So then we can redirect blood towards the more active tissues. So review that. It's a really important concept to understand, and it allows us to survive even conditions where maybe half of our lung is collapsed. Right, gas exchange here. In this picture, right, I will have an extra credit on there, so I'm not going to go into it too much, but understand that if you take a look at this picture right here, inspired air has a PO2 of 160, but when we measure it in the alveolus, the PO2 drops to 104. So there's a 56, all right, millimeters of pressure drop in oxygen. Why? That's substantial, right? That's almost a third of the oxygen's lost, right? Why? That's going to be a question I'm going to ask on an extra credit sheet I'm going to have. And I might have you guys do it next week we meet. In expired air, the PO2 in the alveolus, 104. But when I measure it, when it comes out of your mouth, it magically increased to 120. Why? I want you to think about that, and I'll tell you that it has something to do with our anatomy, right? That's a hint I'll give you. It's an anatomy, right? Now, I'm going to take this one. There's a couple more of these, and then I will stop. Hemoglobin dissociation curve, this and this. If you've taken any BLS classes lately, what they'll tell you is that with the BLS classes, that if you're by yourself, that you might need to just do chest compressions. Why are chest compressions and only chest compressions so important? It's because we now know that when red blood cells, right, when red blood cells travel from your lungs to your tissues and then back, we used to assume that the red blood cells are always, when it comes back, are not going to have a lot of oxygen in it, that they are deoxygenated completely. We know that's not true, right? Now we know that at rest, about 85% of the, or 75 to 80% of the red blood cells that returns back to the lungs, 75% of them will be still saturated, still have a lot of oxygen in it. What this means is that the red blood cells that we carry will always have oxygen. And it's much more important to keep them moving, because if they always have oxygen, they can always unload oxygen as long as blood is moving. That's why compressions are more important than breaths, right? Is because we assume now that there's always going to be oxygen that's going to be available in the red blood cells. And it has to do with this chart. Now, this chart also explains how people are able to survive under much tougher conditions where they can live near the Himalayas, right? Why people can survive at high altitudes. And we'll talk about how coming up. Now, if you take a look at the hemoglobin saturation curve right here, this curve is a sigmoid curve, meaning that it doesn't go straight up in a linear fashion. It goes up right away real quick. And then at the top end, between 70 millimeters of mercury, right here, 70, 80, 90. Well, if we look up there, right, that chart flattens out tremendously. That's what a sigmoid curve does. A sigmoid curve always shows that at the very beginning of the chart, there's a significant rise in that graph. And then towards the tail end, it's almost a plateau. So how does this explain how people are able to live at high sea levels where there's less atmospheric pressure and there's less oxygen? Here's how. So remember what I mentioned, right? At normal sea level, there's 160 millimeters of mercury in our environment. That means in our actual alveoli, 104 millimeters gets into our alveoli. So if we look at 100 right here, we'll see that on the chart, at 100 millimeters of mercury, about 98 to 99% of our hemoglobin is saturated. That means there's the hemoglobin we're carrying, 98, 99% will have oxygen bound to it. Where do we see this? In the lungs, right? That's the only place where we'll see that high of a concentration of oxygen. Is in the lungs, is in the red blood cells that are coming from the lungs going to your systemic arteries. Perfect, right? Now, if you take a look at the top end of the chart right here, look what happens when I go from 100 millimeters of oxygen to 90. Just read that chart right here. At 90, there's a 10% decrease in PO2. Still, there's only a 1% decrease in saturation. We go from 98, 99 to 97. That's not noticeable. So we have decreased the amount of oxygen 10%, right? That means maybe, we're at an area close to Denver, right? Maybe not as high up as Denver, but close. At that point, we have about 89, 90% available oxygen, PO2, but still 97 of our hemoglobin is saturated. Not a huge change. Even when the PO2 drops 20% from 100 to 80, now we are at Denver. What happens? Well, what happens is even when the PO2 is at 80, our percent saturation is still 95%. This means that at very, or even at, like kind of lower amounts of oxygen, we are still able to saturate our red blood cells with oxygen. So 70, we have decreased the amount of oxygen in our environment almost 1/3 now. If you take a look, there's only a 5% drop in the saturation of hemoglobin. You don't feel any kind of issues until you get to be about 88, right? 85% saturation, right? So when we've dropped it almost 1/3, we still have 93% saturation. Just a 5% drop in the amount of oxygen we'll be carrying. That's pretty amazing. That means that we can survive with a lot less oxygen available. And this is what allows us to survive, not us, but our race, right? People to survive in the Himalayas, allows people to survive at very high altitudes in Africa, in Denver, Colorado Springs, right? In Alaska, right? All these people that live near the mountains. Well, what happens in the mountains is you're at higher altitude, lower oxygen content. This is telling us that you can live up to an area with 30% less oxygen. Why? It's because you only have a drop of 5% in saturation. You're still carrying 93% of your red blood cells are saturated with oxygen. Even if you look at 60 millimeters of mercury, at 60 millimeters of mercury, that means that it's almost 40% what it was at sea level. What happens? At 60 millimeters of mercury, we're still 90% saturated. It's only an 8% drop in O2 saturation, even though there's a 40% drop in oxygen content in our environment. Again, allows us to live at a much lower amount of oxygen. Now, people that live in those environments have other things that allows them, other physiological conditions that allows them to survive and thrive in those areas. The people that are living where there's maybe 60 millimeters of oxygen available, well, those people are going to have large chests, barrel-chested people. The lung capacity is going to be much larger when we compare somebody of the same height and weight. So if you have somebody that's 5'10", 130 pounds, and they live in, their whole family lived at sea level, and you compare them with somebody in the Himalayas, and they're 5'10", 130 pounds, and their whole ancestry is in the Himalayas, their lung capacity will be much higher than when we compare to people that live at sea level. Now, what else? Red blood cell count in those people will be much higher as well. So then, even though they're getting less oxygen, they are having less oxygen saturation, right? You have more red blood cells. If you have more red blood cells, you carry more oxygen because there's more oxygen. More red blood cells to carry whatever available lower oxygen levels there are, right? Now, take a look right here. So this chart explains how we can live at higher sea levels. This chart also explains how blood is or oxygen is moved from areas that are more active, right? So then we can have more oxygen to those areas. So then that area can keep up its activity. What do I mean? Right? When the red blood cells leave leave the lungs and goes into your systemic arteries right here, we're at 99% saturation, right? When it goes to an area down here where you have lots and lots of activity, let's say you're jogging. As you're jogging or walking even, you're contracting those muscles of your legs. The more contractions, the more ATPs, the more oxygen you're using. So it makes sense that the oxygen content in those muscles are very low, PO2 of 20, right? So if you have a PO2 of 20, that means that if we're measuring how much oxygen is in those tissues, it's very low. The oxygen content is 20 millimeters of mercury. Why? Well, it's because you're using it to drive aerobic respiration to make ATP. Now, when you look at this chart and a PO2 of 20, that means that the red blood cells that are in that area now, and they're about to leave that area, are only 35% saturated, right? So what we see is that the red blood cells that go to that area is 98% saturated. When it leaves that area, it's 35% saturated. It has unloaded 63% of its oxygen. That's crazy, right? That's a lot of oxygen unloading. And it's a sign that we have unloaded oxygen in the more active tissue, which is exactly what we think, which is exactly what should make sense. Now, how about in a tissue that's not as active? Let's say you're not, since you're jogging, you're not, really working out your arms as much. So you're not bringing blood there. And since you're exercising and you're jogging, you're definitely not bringing, and you're not eating at that point. So your GI tract is not going to be very active at that point either. So if your GI tract isn't active, it's not using up as much oxygen. So the PO2 then in the GI tract would be 40, right? Why? Well, it's not active. It doesn't require a lot of oxygen or glucose because it's not very active. So what happens at a PO2 of 40? PO2 of 40, the red blood cells leaving that area is almost 78%, 76% saturated. That means in an inactive tissue, right, we only unload 30% of our available oxygen. 30%. That's it, right? So in an active tissue, we unload 65%. In an inactive tissue, we unload only 30%. This is a sign that we will unload and load, right? Or unload or not unload oxygen dependent on the activity. So the more active the tissue, the more oxygen it uses, the lower the oxygen content in that area. At that point, the oxygen leaving that area is 35% saturated. So you've unloaded 63% of the oxygen. That means that it favors us, the red blood cells, letting go of oxygen when that tissue is active, right? Makes sense, right? The more active the tissue, the more oxygen it needs. Now, opposite's true, right? The less active the tissue, the more oxygen is available there because it's not using it. If it's not using it, why unload it? So we'll see that in a less active tissue, the PO2 in that area is 40, and you have 75% of the red blood cells leaving that area still saturated. You only unloaded, I said 30, about 23% of the available oxygen, right? This allows us then to then save that oxygen for the more active tissue. Again, limited amount of oxygen, limited amount of blood flow in our body. We only want to direct blood flow to the area that's active. And once we direct the blood flow there, we want to unload oxygen to the more active tissue. That's what this chart really is important for, right? Now I have a chart, all slide videos for the rest of this. So I will stop the recording here.